Now in this part we'll talk about the process of urine formation, and in order to make urine, that involves 3 steps. The first step is glomerular filtration, and that happens in the renal corpuscle, followed by tubular secretion and tubular reabsorption. If you look at the diagram, this here represents the Bowman's capsule with Bowman's space, and then those are the tubules. Anything or any fluid that is present here is now known as the filtrate and will eventually be excreted as urine. These red pipes represent the vascularity that are related to the nephron. So again, your first step would be filtration. So we talked about filtration, how everything pretty much is filtered out due to the hydrostatic pressure, and only the bigger molecules like the big plasma proteins, the bigger our blood cells and so on, cannot be filtered out. Now everything that is filtered, again, if the composition of that filtrate doesn't change, well, all of that will eventually be excreted. But that's not how things work. There are still things in the bloodstream that needs to be excreted, and that will happen through a process known as tubular secretion. So tubular secretion happens in the direction of from the peritubular capillaries into the tubules. While things that we need to be reabsorbed, we do not want to lose all of that glucose and amino acids and vitamins and so on that were filtered out. We want to reabsorb them back into the circulation, and that process is known as tubular reabsorption. So tubular reabsorption happens from the tubules, in the direction of the tubules into the peritubular capillaries. Now the amount that was filtered plus the amount that was secreted minus the amount that was reabsorbed, all of that ends up making the amount of urine that eventually will be excreted. So you can see here a breakdown of how different things work. So you don't need to know these numbers, but it just shows you that why we need tubular reabsorption, for example. So every single day, 180 liters of water are filtered through glomerular filtration. That is a huge amount of water. We only excrete, though, about 2 liters per day. So it ranges between a liter and a half, 1.5 to 2 liters per day, which means that we reabsorb about 99% of the water that was filtered. Again, if you take a look at glucose, 180 grams of glucose are filtered every single day. Again, no glucose appears in urine. This is under normal circumstances. That means that 100% of glucose needs to be reabsorbed. Now, what is glomerular filtration? Well, that is really a very passive process. It is like this bulk flow of water with things that are dissolved in it. And the force behind it is mainly the hydrostatic pressure found inside of the glomerular capillaries. Okay, there are limitations to filtration, and the main limitation would be the size of the molecule. So again, those bigger size molecules are not filtered out. As we mentioned, that the capillaries and the glomeruli are have these very big gaps, and they filter about 180 liters per day. If you compare that to normal capillaries, other capillaries only filter out about 4 liters per day. So you can, compare these, you can see how the renal capillaries are allow for the massive passage of filtrations. Bigger molecules like blood should not appear in the filtrate. If it does, that's known as hematuria. Proteins should not appear in the urine either, and if they do, that is known as proteinuria. So hematuria and proteinuria, if present, that indicates that there is something wrong with that barrier, with these glomerular capillaries. Why are things sneaking out when they shouldn't be. That means that the filtration process is defective. So the hydrostatic pressure is not the only pressure that plays a role in glomerular filtration. It is definitely the main pressure. But there are two other pressures that are in play. So here again is the capillary, and this is the Bowman's capsule. The main pressure here is the glomerular hydrostatic pressure, and that favors filtration. Okay, so filtration again will be from the direction of the glomerular capillary into the space. And the pressure that favors filtration is the hydrostatic pressure of the glomerular capillaries. But remember that the plasma proteins stay behind, and these plasma proteins have the power to pull water back in, and that power is known as the osmotic pressure. And Bowman's space also has water in it, which means that it has its own hydrostatic pressure, and that would want to push water back in the opposite direction. So these two pressures, the osmotic pressure of the glomerular capillaries and the hydrostatic pressure of Bowman's space, both of those oppose filtration. But all of these pressures, the net filtration pressure, definitely happens in the direction of the higher pressure. So the hydrostatic pressure of the glomerular capillaries is higher than the two opposing pressures combined. Now, the glomerular filtration rate is the volume of fluid that is filtered per unit time. It is obviously affected by the health of the glomerular capillaries. It is affected by all of these different pressures in play, the hydrostatic pressure and the osmotic pressure of the glomerular capillaries. Okay, so in other words, at any given net filtration pressure, the GFR, which stands for the glomerular filtration rate, is directly proportionate to the membrane permeability and the surface area, meaning that in the case where there are parts of the kidney that are not healthy, you've decreased the surface area, you've decreased the membrane permeability, and that will definitely lead to a decrease or a lower glomerular filtration rate. We talked about changing the hydrostatic pressure by kind of playing along with the diameters of the afferent versus the efferent arteriole. So in these two scenarios right here, whether we constrict the afferent or dilate the efferent, constrict the afferent here and dilate the efferent down here, both of those scenarios will lead to a decrease in the hydrostatic pressure in the glomerular capillaries, which leads to a decrease in the glomerular filtration rate. But if you do the opposite scenarios, which are constrictions of the efferent or dilation of the afferent, those two scenarios increase the hydrostatic pressure inside of the glomerular capillaries, which increases the filtration, hence that translates into increased glomerular filtration rates. Now, how do the tubules divide the work amongst themselves? Okay, so we talked about how there has to be tubular secretion and tubular reabsorption, but the tubules kind of divide that work. We do know now that filtration happens in the glomerulus, and the majority of tubular reabsorption happens in the proximal convoluted tubules, while most of tubular secretion happens in the distal convoluted tubules. So that division of labor is not perfect. They do kind of overlap a little bit, but the vast majority, again, of tubular reabsorption happens in the proximal tubules, while most of tubular secretion happens in the distal tubules. Now, this is a diagrammatic representation of the tubular epithelium and its relationship to the peritubular capillaries. So that's the lumen of the tubule. That's again where the filtrate is passing. You can see the epithelial cells lining it and the basement membrane with the tight junctions between these cells. You can also see the very close by peritubular capillary. So in order for reabsorption to happen, tubular reabsorption, remember, means that some things that are important to the body will be reabsorbed and move from the tubular lumen to the peritubular capillary to go back to the circulation. Well, in order for that to happen, these molecules would either have to go through the cell, and that process is known as transcellular transport, or they would have to go through these tight junctions, and that is known as paracellular transport. You'll find that some of these transports are active, for example, the tubular reabsorption of sodium, while other kinds of transport are passive. For example, urea and uric acid. They will go kind of down their concentration gradient. But remember that urea and uric acid are toxic compounds, so the body will actually secrete it back again into the tubules later on using the process known as tubular secretion. Since sodium is extremely important to the body, we've talked about sodium in the terms of action potentials, in the terms of muscle contraction, and so on. So sodium, we filter all of the sodium during glomerular filtration, or at least the majority of it. We need to reabsorb all of that back. Okay, so sodium is the most abundant cation that is found in the filtrate, and again, we want to conserve, we want to keep that sodium. So sodium will be reabsorbed in this active process. It happens throughout all of the tubular system with one exception, and that is the descending limb of the loop of Henle. The descending limb does not allow for the passage of any ions, okay, not just sodium. Sodium is usually reabsorbed in the form of using the active pump known as the sodium-potassium pump. So using that enzyme sodium-potassium ATPase to fuel it. And sodium is kind of like a friendly ion. It doesn't like to travel alone. So sometimes it co-transports other molecules. So it can co-transport glucose and amino acids. And that's how one of the ways we reabsorb glucose back into the capillaries. The only downside to this is that because glucose is co-transported with sodium, and these carriers can be saturated. So in diabetic patients, for example, that have hyperglycemia, well, once these carriers are saturated, I don't have any more carriers to carry that excess glucose. So that glucose will eventually end up being in urine, and that process is known as glucosuria. Glucose will pull lots of water with it, leading to polyuria. And that leads to excessive thirst and dehydration in diabetic patients that are not controlled. So we were just talking about this, where patients that with uncontrolled diabetes reach that transport maximum in regards to glucose reabsorption, because again, the reabsorption of glucose is limited to the number of carriers, protein carriers that can help in this process. So again, in uncontrolled diabetic patients that have hyperglycemia, all of that excess glucose will eventually end up being excreted in urine. Now, tubular secretion, that's again when we have things in our bloodstream that we want to get rid of. So for example, excess hydrogen ions, excess potassium, any drugs or medications, the urea and uric acid that we reabsorbed passively due to the down its concentration gradient that we talked about earlier. So all of these are things that will end up being secreted. Okay, so for example, disposing of drugs and their drug metabolites, eliminating things that we don't need like urea and uric acid, removing any excess potassium, and controlling the blood pH through the secretion of hydrogen ions. Now we've got lots of different channels and lots of different transporters, not just for sodium and glucose, but for everything else that has to kind of pass, whether it be reabsorbed or secreted. And all of these transporters and channels are regulated by hormones. These hormones could be paracrine hormones or even autocrine hormones. Renal clearance, that means how much plasma has to be filtered in order to get rid of a certain substance. So again, renal clearance of a substance is the volume of plasma from which that substance is completely removed or cleared by the kidneys per unit time. For example, if a patient is injected inulin, inulin is an organic polysaccharide that can be derived from plants. When injected into a patient, we want to find out how long inulin is a substance that is only filtered. It is not secreted or reabsorbed. Being that it is just filtered, it gives us a good idea, or actually a perfect idea, about the glomerular filtration rate. Okay, but we don't really want to expose patients to unnecessary products. Okay, you never know who might be allergic to it, so an easier way to detect or to give us a good close idea of glomerular filtration rates would be to look at the renal clearance of creatinine. The only downside to this is that creatinine, although it obviously is filtered, but it is also slightly secreted. So you want to kind of, when you look at the numbers, you might want to adjust for that slight secretion. But again, it does give us a pretty good idea as to the glomerular filtration rates of the kidneys and the overall health of the kidney. Now that we've made urine, how is it that we get rid of it? And that process is known as urination or micturition. The urinary bladder is that sac. The wall has a smooth muscle known as the detrusor muscle. It does allow for the distension or the expansion of the urinary bladder. But when it reaches, when it fills up, okay, that stimulates that stretch of the bladder wall will stimulate the micturition reflex. The reflex center is found in the spinal cord, and it involves the contraction of the detrusor muscle and the relaxation of the internal urethral sphincter. So the urethra has two sphincters, one on the inside, one that is proximal, known as the internal urethral sphincter, and another distal one called the external urethral sphincter. The internal sphincter is made out of smooth muscle fibers that is under autonomic control, while the external sphincter is skeletal muscle, and that is under somatic control. So you can see here the bladder with the detrusor muscle. You can see that this is where the internal urethral sphincter is, which is pretty much where the bladder meets the urethra. That again is our smooth muscle fibers under the autonomic nervous system control, while the external sphincter, those are skeletal muscle fibers, and those are under the somatic control. So take a look at all of these different muscles. So again, the detrusor, that's smooth muscle, and the parasympathetic control, or the parasympathetic innervation of the detrusor muscle, leads to its contraction. Okay, so when we're ready to evacuate the bladder, the parasympathetic will send signals to the detrusor muscles to contract. Now, the internal urethral sphincter is normally contracted by the sympathetic nervous system. The body would have to inhibit the sympathetic system in order to relax that sphincter. Okay, that is all as a reflex. The part that we can control, though, are these external urethral sphincters. So if we're not in a situation where we can actually empty the bladder, so we're basically not in the bathroom, the somatic nervous system will send impulses to that muscle to remain contracted. When the conditions are favorable and we're ready to evacuate the bladder, all we have to do is relax that muscle, and now the detrusor muscle contracts, the internal sphincter is relaxed, and we voluntarily relax the external sphincter. Incontinence, that is a condition where there is an involuntary release of urine. Incontinence is more common to happen in women than in men. And the most common kinds of incontinence are stress and urge incontinence. So stress incontinence, that usually happens not because of psychological stress, but stress here means an increase in the intra-abdominal and intrapelvic pressure. So for example, sneezing or coughing causes a sudden increase in the intra-abdominal pressure, and that can lead to the escape of some urine out of the bladder. So that's known as stress incontinence. Again, this definitely is more common in women due to, especially after pregnancy and after delivery, due to the weakness of the pelvic floor muscles. The external urethral sphincter is considered one of those pelvic floor muscles, and that is why post-delivery women are advised to perform pelvic floor exercises in order to prevent stress incontinence from happening. Now, urge incontinence, that means that after emptying the bladder, the person feels like maybe half an hour later that they need to empty the bladder again. So kind of like the increase in the frequency or the desire to keep on urinating. And that is usually due to the hyperexcitability of the detrusor muscle. It could be due to a urinary tract infection. For example, the different medications that are used in these incontinences, especially for stress incontinence, we tend to use medications that have these estrogen replacement therapy to help improve the tone of the pelvic floor muscle fibers. And then in the case of the urge incontinence, we can give things that inhibit the detrusor muscle. They're known as bladder relaxants. For example, Detrol and Oxytrol, both of these are anticholinergic. Remember, acetylcholine is related to parasympathetic. So anticholinergic medication would inhibit the parasympathetic or would block the cholinergic receptors, kind of inhibiting, blocking the effect of the parasympathetic on the detrusor muscle, and that relaxes the detrusor muscle. The only thing, though, that it has a couple of side effects like blurred vision, can lead to constipation, and can lead to tachycardia. Now in the next tutorial, we'll be talking about dilution versus the concentration of urine.